Okay, so we are live now, and with all your concern, I'm starting the session. Good evening, and a warm welcome to all the dignitaries present here. Myself, Rupsha from ClearNet, assigned as a station assistant to ensure a seamless experience. ClearNet stands as India's most reliable digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that ClearNet is a digital partner of this event organized by National Neonatology Forum, Gujarat. And the topic of today's session is case presentation on congenital heart disease. So, without any further delay, I would like to hand over this topic to Kunal sir. Over to you, sir. Please proceed with your talk.
Yeah, thank you so much, Utsa. So today we are continuing with our neonatal Pathshala, which is an online program which we are conducting every Wednesday between 3 to 4 p.m. Today we are having a case presentation by Dr. Mansi. We are lucky to have Dr. Sandeep with us, who will be an expert for today, and the session is mentored by Dr. Maulik Sasal. So thank you so much, sir, for joining with us. Before starting the session, I would request Shwetal ma'am to say a few words.
Thank you so much, Kunal, for good introduction. Kunal, there is some glitch with my phone. Hello, Kunal, can you hear me?
Yes, ma'am, you are clear.
Okay, fine.
Yeah.
Thank you so much, Kunal. This is our again a case presentation series. We want to encourage the postgraduate to present the case and sharpen their presenting as well as the clinical skills. And for that, we have always, I am really very thankful to Dr. Sandeep, one of the only one DM neonatologist of Gujarat who is always ready to be an expert faculty. So thank you so much, Dr. Sandeep, for accepting our invitation. And I think I can, Krunal, you can introduce our mentor, Dr. Maulik, sir.
Krunal, you need to unmute.
Yes. It is my honor and privilege to introduce a dear friend of mine, Dr. Maulik Shah, who is a medical teacher since last 19 years. He's an assistant professor at MP Shah Medical College, Jamnagar, and in charge of the sick newborn care unit at the Government Hospital, Jamnagar since 2009. And his keen interest is in audiovisual content creation for health projects, podcasts, social media content strategy, YouTube content creations, and blog and website creations. And this is a short introduction for him, and he's a well-known person in our neonatology. I'll hand over to Dr. Maulik Shah.
Kunal, we can start with the session. You can just introduce Dr. Sandeep and Mansi, and then Mansi will start with the session.
Okay.
Yeah.
Dr. Sandeep Tilwani, sir, is the DM neonatology. He has done his studies from Government Medical College, Tamil Nadu. His current designation is Assistant Professor, Division of Neonatology, Department of Pediatrics, Bhuj. And his areas of interest is infection control in NICU, neonatal nutrition, neonatal neurology, quality improvement in neonatal care, neonatal nursing care. And today's case patient is Dr. Mansi. She will start now the case and we can proceed further.
Can I start?
Yes, Mansi.
Good evening, respected dignitaries who are present here. So myself, Mansi Bowser, I'm third-year resident from MP Shah Medical College, Jamnagar, and I have prepared a case under guidance of Dr. Maulik Shah, sir. I am presenting a case of a female newborn born in our hospital, GG Hospital, Jamnagar, presenting in our NICU at the first hour of life. born with lower segmental cesarean section on 31st August 2024 at 10:50 p.m. Her gestational age was 34 weeks and born with 1.6 kg of birth weight. She was born with non-consanguineous marriage, and there were no history of any hereditary disease or any major illness in her family. In antenatal history, her mother's age was 23-year-old primi gravida with active marriage life of 2 years. Her LMP was 6 January 2024, and expected date of delivery was 30th October 2024. Her mother's blood group was O positive, and there were no past history of hospitalization or hypertension, or no history of any radiation exposure in the mother, or no history of smoking, alcohol use, or any drug intake in mother. In the history of first trimester, mother taken regular visit at private hospital. She was diagnosed by urinary pregnancy test at private hospital, and she was tested negative for HIV, HBsAg, and VDRL in the private hospital. She has taken folic acid regularly since first trimester, and no history of fever, hypertension, diabetes, or hypothyroidism. Her HB was 11.5, which was done at 5th week of gestation, and first USG was done at 10th week, which was suggestive of triplet pregnancy. In history of second trimester, at the 17th week of gestation, mother had history of fever and admitted in our hospital with a history of fever since 7 days. She had no other complaint except fever, and some investigation was sent which was suggestive of HB was fall down to 8.5 gram percentage, and CRP was 257. Other tests like Vidal, dengue, and malarial parasite was negative, and her urine RM was positive. 8 to 10 pus cells was found. RBS was normal at that time, and the 2 fever spike at a time at a day of admission was present. Patient treated with antibiotic, and 2 point PCV was given during hospital stay. Mother was admitted 6 days in our hospital, and discharged after being afebrile for 2 days. Both iron and calcium supplementation was taken regularly during second trimester, and the second days 2 doses of TD was given 4 weeks apart during second trimester. At 17th week of gestation, the USG was done suggestive of triplet pregnancy, which was dichorionic diamnionic. And at 21st week of gestation, the anomaly scan was done, which was suggestive of no gross congenital anomaly in any of the triplet. Intertwin membrane was present with normal fetal biometry. On third trimester history, mother has no history of any radiation exposure or any teratogenic drug intake during pregnancy, or no history of diabetes in pregnancy. Mother had no history of fever, burning, micturition, or pervaginal discharge during third trimester of pregnancy. Mother's weight was 60 kg, and routine scan was done as 33 week of gestation. It was suggestive of a discrepancy of 5 weeks in T3 in compared to other two twin. Her abdominal circumference and expected fetal weight was less than 2.5 percentile, and it was suggestive of symmetrical IUGR. Her cerebroplacental ratio was less than 1, and umbilical artery Doppler suggestive of absent diastolic flow, and middle cerebral artery Doppler suggestive of increased diastolic flow. So the mother was taken for emergency cesarean section under spinal anesthesia. Baby received in plastic wrap, which all babies cry soon after birth. But there was no anatomical abnormalities in any of the baby. All 3 female child was born. First T1 was born at 10:55 p.m., which was cephalic presentation, and other 2 child was delivered by breech presentation. The first 2 child weight was 1.6 and 1.5 kg. The third child weight difference was more than 25 percentile than other two child, which was 975 gram. All babies cry soon after birth, and her Apgar score at 5 minutes was more than 9. The first 2 child T1 and T2 was appropriate for gestational age, and the third child was small for gestational age. The gestational age was on USG, third trimester USG for first T1 was 34 week, for T2 was 33 week, 2 days, and for T3 was 29 week plus 5 days. All newborn kept under observation due to low birth weight. All were vitally stable on first hour of life. RBS was normal. Spoon feeding was started in T1 and T2 with formula feed, and in T3, RTF was started. All three septic at 24 hours of life, septic screen was sent for all three newborns, and which was negative. So for the first 3 days, all the triplets were normal and under observation in our NIC. On the day of life 4, the T1 it was observed that for the triplet 1, the weight loss was around 150 gram, and on the 4th day of life, the weight was 1.445 kg. The weight loss present for 3 consecutive days for T1. She passed urine and stool normally. Her SpO2 was normal, no tachypnea, no distress. She was vitally stable. So patient kept on full RTF. The investigation sent again on day 4, which was normal. CRP was negative. Blood CS was sent, and WBC count was also normal. Her HB was around 14.6, and other electrolytes was normal limit, and RBS was also normal. On the day of life 5, the patient develop the subcostal retraction, and so we measure the saturation of the patient, which was 84% on rumor. So we gave O2 support with the nasal cannula to the baby. After the O2 support, the saturation did not improve. We have observed that the patient has peripheral cyanosis, and on vital monitoring, her pulse rate was 130 to 150 per minute. RS was clear, bilateral equal air entry, and on CVS, loud S1 was there, and soft systolic murmur was there. On general examination, she has mild pallor, periphery was sinus, no icterus, no edema was there, and we have done chest X-ray of the patient. So I'm showing the chest X-ray of the patient, which was suggestive of there is cardiomegaly, and cardiothoracic ratio was around 7 at that time. There is no pulmonary blood flow is seen in the X-ray. So we have done 2D echo for the patient. The 2D echo finding, which was suggestive of there was a dilated right atrium with the 3 millimeter PFO with the left to right shunt. A severe tricuspid regurgitation was seen in subcostal view with a tricuspid velocity maximum 3.39 minute per second, and pulmonary gradient was 46.5 millimeter of mercury. The displacement index was 29 millimeter per meter square, which was significant. So it is suggestive of there is displacement of tricuspid valve, septal leaflet of tricuspid valve in compared to mitral valve attachment on the septum. Her IVC was dilated and collapsible, and there was decreased cardiac contractility. There was small functional right ventricle was present, but it is observed that patient has pulmonary stenosis. So there was a 2D echo was done, and this 2D echo suggestive that the second image is suggestive that there was tricuspid regurgitation, and the regurgitation jet is around 46 millimeter of mercury. And the first image in this suggestive that there is a pulmonary stenosis is there, and there is also observed that there is right atrium dilatation was seen. In the second image, we can see that there is a septal attachment of mitral valve and a septal attachment of tricuspid valve. The tricuspid valve attachment is below the mitral valve. So, and the right atrium is dilated. So we can see the atrialization of right ventricle in some part, and there is a decrease in size of functional right ventricle. And it is also seen that there is a PFO is also seen in the second image. The patient was further deteriorated on the same day. She has persistent peripheral cyanosis, mottling, and her temperature was normal. There is a chest indrawing was severe, and facial puffiness also present. So we have intubated the child and kept on ventilator. The vitals after intubation also SpO2 was not increasing, SpO2 82% on ventilator with FiO2 100%. The peak inspiratory pressure was 5 and peak expiratory pressure was 5 and inspiratory was 10. Inspiratory gem expiratory ratio 1 gem 2. And her pulse rate was normal at that time. We have done ABGA after 30 minutes of intubation. At that time, patient showing blood pH was 7.3 and Bicar was 5.2, which was suggestive of metabolic acidosis. PCO2 was 8.3. Her saturation in the blood was 70%. Her IVC was dilated, so we have started 2/3 of total IVF on that day of life. We have started PGE1. We have suspected some duct-dependent condition, so the PGE1 was started, and injection Dobuta and injection Lasix was started to prevent cardiac failure in the child. We have started empirical antibiotic, and tablet sildenafil was given to decrease pulmonary blood flow resistance. Patient was kept for under sedation by giving Medastil. On day of life 6, patient still still SpO2 was around 80 to 90, on FiO2 100%, with peak expiratory flow was 5. Temperature was normal, and her child was CRT was prolonged more than 3 seconds. IVC was dilated and mean blood pressure 30 mmHg. Pulse volume was moderate in periphery and good in central pulses. RBS was normal at that time. On the day of life 6, we have observed that the baby's heart rate was gradually increasing. We have observed that in the morning 9 p.m. it was a 124 heart rate, which was gradually increasing, and at the 6 p.m. it was 210, and 9 p.m. it was 225 per minute. So we have done ECG of the patient, and the ECG is showing like this in lead 2. There is narrow QRS complex, and we cannot find any distinct P wave in the ECG. So we have suspected there is a supraventricular tachycardia. So we have given in the injection adenosine 0.1 mg per kg in the straight dose, but the heart rate still more than 220. So we have given another dose of injection adenosine 0.2 mg per kg. Heart rate was still persistently more than 220. So another dose of injection maximum dose of adenosine was given. So we have given injection amiodarone at 5 mg per kg loading dose over 30 minutes in state. Patient heart rate still more than 220. So amiodarone drip was started, and we have given beta blocker propranolol 0.5 mg per kg. After that, patient heart rate was gradually starts decreasing. On the second, on the same day in afternoon, the patient heart rate reaches up to 163, and the respiratory rate was around 60. Patient saturation was still around 80% on ventilator. On day of life 7, patient heart rate was less than 100, so we have decreased propranolol dose to the 0.25 mg per kg. Our peripheral pulse and saturation was gradually improved, and CRT was gradually improved. Alprostadil was continued. Day of life 10, we were able to start feeding formula feed in the child at 2 ml per kg per day, and we are gradually increase the feed. Right now there is a 18th day of life. Baby is still on ventilator, and baby is on feed of around 50 ml per kg per day. Rest IVF is continued. There was a case of late preterm female, appropriate for date. T1 of triplet born at 34 weeker, admitted in NICU for low birth weight, respiratory distress, congenital heart disease, suspected Epstein anomaly leading to supraventricular tachycardia.
Okay. Yeah. So first of all, congratulations to the team for managing the case so well. Now starting with the questions. As you told, this is actually mother is what gravida, primary gravida mother.
Yes, ma'am. Yes, sir.
Okay. And there is no previous history of CHD in any of the family members, or no history of recurrent abortions or anything. Okay. And how are the other two babies other than this one?
Sir, other two babies are both are on room air and both are tolerating feeding well.
Okay. So yeah. So then since you have described it in the case, I'll focus on the other two also. So one of the babies was around 930 grams. Right?
Yes, sir.
Okay,
Yes.
and for this baby also at 34 weeks, female child, the birth weight was 1.6 kgs.
Yes, sir.
Okay, so I mean, is it coming as AGA or SGA? I mean,
Sir, T1 is coming as AGA and T3 is coming as SGA.
okay, so that SGA is quite severe, right? I mean, it is less than the third centile, if I'm not wrong.
Yes, sir.
34 weeks, 930 grams would be less than the third centile. So, okay, so if that is the case, how do you proceed with feeding that baby? I mean, on day one, how do you proceed, or what is the concern in feeding that child on day one for that severe IUGR baby?
Sir, first we have to measure the RBS of the child because IUGR babies are most likely to going into hypoglycemia. We will
Okay.
start feeding under observation. If patient is tolerating, then we will like to start RT feeding according to the day of life. Like in first day, we are starting with a 60 ml per kg per day feeding 900 gram. We will start with RT feeding.
Okay, so what do you mean by feeding a baby with AREDF? Have you heard anything about that? AREDF.
No, sir.
Okay, you have mentioned it also in your summary. It is absent in diastolic flow, I think, in
Okay,
the
sir. Yes.
yeah. So absent or reversed,
And
absent
diastolic blood.
reversed and diastolic flow in the umbilical artery. So when you are dealing with a IUGR baby, especially with a baby who is having some Doppler changes in the antenatal scan, I mean, do you know any protocol? I mean, like rather, what is the concern in initiating feeds in such babies?
There will be less intestinal blood supply in that baby. So
Okay.
baby, so most likely baby will. So we will start we'll gradually increase the baby. We will start with minimal enteral feed.
Okay. So do you know any trial, any studies which have focused on this issue about feeding the babies with absent or reduced end diastolic flow?
Sir.
Okay. Anything about the ADAPT trial, ADEPT trial? Okay. Okay. So one of the concerns with feeding such IUGR, such severe IUGR babies is that most of the times they may not tolerate feeds, and you have to go very slow, and you expect some turbulent course while establishing feeds for such babies. Okay, I'm happy that this child doesn't have, but I mean, most of the times we do expect some turbulence. Okay. Then, so coming to this baby, when did the deterioration start? I mean, you told that the baby was doing quite well in the first 2 to 3 days, right?
Yes, sir.
Okay, so when did the deterioration start?
Sir, on day of life 4, deterioration started. For first 3 days. For first 3 days, the triplet 1 was also tolerating feeding well.
Okay.
Deterioration started on day 4.
Okay, so okay, so deterioration started on day 4. Before that, the child was totally fine. Antenatal scans, they were not suggestive of anything abnormal.
No, sir. Antenatal
Okay.
in antenatal scan, no fetal echo was done or not suggestive of any abnormal.
Okay. So, okay. Then, what explains the severe IUGR for the third triplet? I mean, just out of the way, I'm asking that question. What explains the severe IUGR for the third triplet?
Sir, the weight discrepancy between the other twin and the IUGR twin was around 25%, and the weight of the IUGR twin was less than 10th percentile of normal weight newborn.
Okay, but then you have to find, I mean, you have to do something to find a cause, right? Because, I mean, it is not normal. When other two of the this thing babies have a weight of 1.5 and 1.6. So this baby also should grow ideally to somewhat near to that. Okay. So when that baby is born at 930 grams, what should you do next? What is the most probable reason that the child had IUGR?
Uh, Sir, these are in this case, sir, there may be these child are dichorionic diamnionic twins. But in case of monochorionic diamniotic twins, there is chances of twin transfusion syndrome. In that case, baby also didn't gain weight.
Transfusion, okay. I mean, when you have a this thing, common chorion or this thing, it may happen. Okay, this is all three had a separate placenta, right? So, what do you expect? What would be the problem?
Sir, in this case, the third baby is 4 weeks below than other two twins. So there may be superfetation, case of superfetation.
No. Usually, I mean that 4 weeks below is because that scan was done on just prior to the delivery. I feel right. So that just suggests that there is a growth lag. I mean that 4 weeks difference. I mean even in one of the slides you have shown that the third of the triplets was 29 plus 5 at gestation. Okay, so that is just prior to the delivery, but otherwise all three would be 34 weeks of gestation. Usually it won't happen that there is 5 weeks after conceiving one this thing second pregnancy will happen. Okay, so what it suggests is that 29 plus 5, what does it suggest is that there is a growth lag. Okay,
Yes.
it only suggests that the fetus has not grown, the third fetus has not grown to the potential of other two babies, and there's a growth lag of 5 weeks between the as compared to the other two normal fetuses. Okay,
Yes.
so when second fetus is born, I mean, most probable explanation would be that because there were three different placenta, maybe one of the placenta, there may be some defects with the attachment of the placenta or some cord abnormality. And when you have such a this thing IUGR baby, I mean, what from our side, what we can do is at least retrospectively just to establish the cause for that IUGR, you can go and have a look at the placenta just to see whether the placentation was normal or any abnormalities with the placentation. Okay, because I mean it is expected that there will not be so much of space for three placenta to grow adequately inside the uterus. So maybe one of the placenta was not properly attached. There may be some defects in the placentation, and that has led to IUGR for this third triplet. Okay.
Yes.
Okay. Then okay. So next question was regarding the feeding protocol in IUGR babies. Okay. So whenever you are dealing with IUGR, I mean always a area of concern is that they may not tolerate feeds, especially in those babies where there was antenatal Doppler abnormalities, depending on how severe the abnormality was. Okay. So I mean, especially for babies with absent or reversed end diastolic flow in the umbilical arteries, you have to be a bit more cautious. Okay. Third thing is there something I mean we could have done to detect this, or do you know of any screening test to diagnose CHD in the newborns early?
Anomaly
See,
scan at 18
okay.
to
So
22 weeks.
this baby was 34 weeks of gestation and 1.6 kg. So this baby was admitted to your NICU. But suppose if this baby was 38 weeker, 2.6 kgs, everything else is fine, shifted to mother side on day one. Okay, is there something you can do to screen for the presence of heart diseases in these babies in the postnatal ward or even inside the NICU also?
Hyperoxia test.
Okay, hyperoxia test, I mean, you cannot do for all the babies, right? I mean, I'm asking about a screening test. So screening test is something that you can do for all the babies. Okay, just prior to their discharge.
All saturation in SpO2 monitoring, pulse ox, and heart rate monitoring.
Okay, so pulse oximetry, I mean, okay. So, I mean, is it something which is recommended by the Indian authorities? Anything you know about it? The government guidelines my question that screening has to be done. Anything about the pulse oximetry screening?
No.
Okay. Okay. I'll just deviate from the topic a little bit. What is RBSK?
राष्ट्रीय बाल स्वास्थ्य कार्यक्रम.
Yeah. Okay. So what does it primarily deal with?
RBSK primarily deal with free services of RBSK primarily deal with 4D like
What are those four? What are those 4Ds?
Deficiencies, developmental defect,
What else? One is deficiencies, one is
deficiency,
development.
developmental defect. Another D is
Okay, okay. So, okay. So one of these diseases. Okay, and one of the diseases which is covered under this is congenital heart diseases. Okay, so as per the government protocol, also you need to screen for these babies. Okay, prior to discharge from the hospital. Okay, and since it is a screening test, it has to be something which can be done quickly and bedside. Okay, and so one of the screening tests is your pulse oximetry screening.
yes.
Okay. So what do we do in pulse oximetry screening? How do you do it?
I will attach the pulse oximeter with the all four limbs of the baby, and we will see the saturation of the newborn, which will normally it will more than 92% on room air. And if there is a difference between right up preductal and postductal, and so it will most likely to be heart disease.
No. So see, this pulse oximetry screening, you need to check the preductal and postductal saturations. Okay, there is no need to screen for all the four limbs. Okay, now recently in 2020, the American Academy also has revised their guidelines, and to some extent we are also following it only. That it is not necessary to do a four-limb SpO2 screening. It is okay even if you do preductal and postductal, one preductal and one postductal. Okay, so preductal we take it as right upper limb, and postductal can be either of the two lower limbs. Okay, so either right or left lower limb, because left upper limb may be preductal in some babies, so we do not take the left upper limb. Okay, so what you do is you take the saturation in the right upper limb, and then either in the left or right lower limb. Okay, and what is the this thing? So either of the two lower limbs is fine. So instead of four limb, we do only two limbs because we want to screen. Okay, and like I mean, see, you are from a very busy unit, right? Jamnagar is a very busy unit. So from that busy unit, like suppose from your postnatal ward, if you have some 120, 130, 150 babies in your postnatal ward, it is not possible to do four limb SpO2 for all babies. Okay, so the idea is that like you should have one preductal, one postductal. Okay, when it should be done? What is the ideal time to do that screening?
Ideal time to do it after 24 hours of life.
Okay, so why do we want to wait for 24 hours?
Because babies may have cyanosis and may have at the first minute of life, it was saturation was normally 65 to 70%, and it
Okay,
will
so
gradually increase at 5 to 10 minutes after birth.
okay. So basically, it is, I mean, we preferably wait for 24 hours because we want to decrease the false positive rates. Okay, the screening may come positive because of respiratory illnesses. Sometimes when the child is having RDS and your alveoli are not, adequately expanded. So even with this thing, your saturation, even after giving a proper support, sometimes the child may not saturate well. Okay, so to just to tide over that, we are giving a window period of say 24 hours. Okay, just to decrease the false positive rate. Okay, so and this pulse oximetry, what is the cutoff? I mean, beyond what do you consider it positive? How do you interpret it?
Sir, up to the 94% it is normal. More than or equal to 94% on room air.
Yeah, so it has to be more than 94. Anything 95 or above. Okay. So now the cutoff is very clear, 95 and above, and that too it has to be both preductal and postductal. The cutoff has to be 95 and above. Okay, I mean earlier it was that in preductal it should be more than 95, and postductal it is okay if it goes below, I mean between 90 to 94. Now it is very clear in the guidelines that for both preductal and postductal it has to be more than 95. One. Second, the difference between preductal and postductal, it has to be less than or equal to 3. Okay, so if the difference between preductal and postductal, if it is coming out to be 4 or more, even that is your this thing sign that maybe there is an underlying CHD. Okay, right. Okay, so this was about the pulse oximetry screening. Now, which are the diseases which could ideally be, detected by this pulse oximetry screening? Any idea? It actually targets some certain set of diseases.
respiratory disorder, respiratory disorder, or maybe
No,
metabolic
only cardiac diseases, only congenital heart diseases. But in that also, I mean, not all the congenital heart diseases would have a pulse oximetry screening positive. I mean, if you have a simple VSD or ASD or a small PDA, this thing may not be positive. Okay, so there are certain set of congenital heart diseases which you are targeting when you are doing a pulse oximetry screening.
the TGA,
Okay, correct.
TGA, TAPVC, tricuspid atresia,
Okay,
like, hypoplastic left heart syndrome,
okay.
coarctation of aorta.
No, that is one of the diseases that is not diagnosed. Okay, so one of the fallacies with this pulse oximetry screening is that left side obstructive heart lesions like severe aortic stenosis or your coarctation of aorta, aortic arch abnormalities, or even your this thing, small mixing lesions like ASD, VSD, or PDA may not be picked up. Okay, but then there are certain set of common congenital heart diseases which definitely will get picked up, as you mentioned earlier: TGA, TAPVC, tricuspid atresia, hypoplastic left heart. Okay, so these are the conditions which would be easily picked up, right? And because I mean we are discussing an exam case, sometimes they may ask you what is the sensitivity and specificity of this pulse oximetry screening, how reliable it is. Because see, I mean, it is a screening test. Okay, gold standard is always your echo. So as compared to that gold standard, how reliable is your screening test?
The sensitivity is more than 90%.
No, sensitivity is around 77% and specificity is quite high, that is 99.9%. Okay. So, and okay, so by the way, what is sensitivity and what is specificity?
So sensitivity is done for screening. Sensitivity is useful for screening purpose. We can, in the sample size, we can detect maximum number, which is positive, and specificity is which is true positive for the test.
True positive. No, it is true negatives for the test. Specificity is true negatives.
True negative.
Okay. Okay. Then, okay. I think from pediatrics, you would have read about the NADA's criteria for suspecting CHD. What is that?
Sorry, sir.
NADA's criteria for suspecting congenital heart disease.
Okay, sir.
What?
There is some major criteria and minor criteria. In major criteria, there is systolic murmur more than 3 grade, diastolic murmur of any grade. There is a patient presented with congestive cardiac failure, and there is a cyanosis present. In the minor criteria, the systolic murmur less than grade 3, or abnormality of second heart sound, blood pressure, X-ray, and ECG. If present of one major criteria or two minor criteria, the NADA's criteria is positive for congenital heart disease.
Okay. Then about this, you had started one drug called L-prostadil, right?
Yes, sir.
So what is that drug?
So alprostadil is prostaglandin PGE2 inhibitor. It will cause
which inhibitor?
Sorry, sir.
What is that drug? Sorry.
Alprostadil is PGE1 inhibitor.
No, not inhibitor. It is not inhibitor.
Sorry, sir. It is PGE1. It is prostaglandin, increased prostaglandin. So it will.
That is actually prostaglandin. It is not inhibitor.
It is not inhibitor, sir.
How does it help? What does it do?
It is it will kept duct open. So it is used in duct dependent condition.
Okay. So do you know the dose of that drug?
Yes, sir. It is started with 0.5 mg per kg per minute.
Not mg, it is microgram.
Microgram per kg per minute. 0.05 microgram per kg per minute.
And what is the most common side effect associated with this drug?
Most common side effect is hypotension.
No, it's apnea. Okay. It
Apnea.
may be associated with bradycardia or tachycardia, hypotension, may be associated with apnea, fever. But of all the side effects, most common side effect which you see very often is apnea. Okay, so that is why even if you are suspecting CHD in a baby, and if you are starting prostaglandin, be very sure that sooner or later the child is going to need some form of respiratory support for apnea. Okay. Okay. And then you said that the baby also developed arrhythmia.
Yes, sir.
Okay.
On day
So,
of life.
okay. So, what drug did you use for it?
Sir, we have given first we have started with injection adenosine.
Okay. Okay. So, what is the mechanism of action of that drug, or how does it help?
Sir, adenosine it will block the additional pathway which is going from SN node to AV node. So
Okay.
it will control the heart.
What is the dose for that drug?
Sir, maximum dose in the neonate is 0.3 mg per kg.
Okay.
So
And what precaution you have to take while administering that drug?
sir, drug administration, we have given the drug in single shot because it has shorter half-life in seconds. So we are giving a single shot of the drug with the saline push.
Okay. So what I mean with saline push, but I mean it is ultra short acting drug, right?
Yes.
So by the time you push, you push the drug and you remove, and then you push the saline, it is going to the effect is going to be lost. So to avoid that, what you do?
Sir, I will give we will give adenosine from a single shot, and then we will immediately after that we will push the saline 5 ml after the drug.
No, I mean, so that is what you call that this thing technique.
Sorry, sir.
I mean, you use it with a three-way stopcock, right?
Yes, sir. We will use
One
it
hand you
with
can-
3-way.
Okay, okay, okay. Then can you interpret the ABG? You had shown one blood gas. No?
Sir, pH is 7.3 and the bicarbonate was 5.2. It is suggestive of PCO2 was 8.3. It is suggestive of metabolic acidosis, and the saturation was already 70%. Base exchange was minus 20. So it can be it is due to hypoxia.
Okay. What does this base ECF suggest? What is the significance of this base excess minus 20?
The decrease in it is suggestive of baby is in chronic hypoxia.
No, rather it is indicator of the metabolic status. Okay, so because the child has profound metabolic acidosis, there is a base deficit of 20 millimoles. Okay, so I mean, see, your bicarb and CO2 may increase or decrease as a part of compensation, but base ECF is something which is more correct a marker of the metabolic status of the baby. So if that is minus 20, normally how much should be the value of base ECF?
Minus 2 to 3 minus.
Minus 2 to?
Minus 2 to minus 3.
No, it is minus 2 to plus 2. Okay. And I mean, so I mean, if the child is sick, I will even accept minus 5 to plus 5. But anything beyond that, I mean, anything less than minus 5 or this thing, so it indicates that the acid base status or the perfusion as such, the metabolic status is not good. Okay. Okay. Then, a little bit about the pulse oximeter as such. I mean, do you know what is the principle of pulse oximetry? Since we have discussed so much about pulse oximetry screening and all those things, what is the principle of pulse oximeter, of using of that pulse oximeter? I mean, all of us are using it, no, day in day out in our NICUs. So what is the principle behind use of that pulse oximeter, or how does it sense the saturation?
It will detect the oxygen content of the blood by infrared waves.
Okay, infrared, and what else? Which other type of waves are used? There are two lights. Okay, that sensor. I mean, if you see that sensor properly,
Yes.
always there is a light blinking in it, right? So
Yes.
those are actually two different lights. One is the red light and one is the infrared light. Okay. And what is the principle? I mean, there is the name of a law based on which this pulse oximetry screening, pulse oximeter use is based. Okay. Okay. So go and read about the Beer-Lambert law. Okay. Beer-Lambert law. It is the law based on which the pulse oximeter is entire this principle of pulse oximeter is based. Okay, and I mean one more question is, why do we use only the arterial pulsations? Why don't we use venous pulsations or capillary or this thing? I mean, why is the device devised in such a way that it is only recording the arterial this thing saturation? Whatever you are seeing is the arterial saturation, right? You are not seeing the venous saturation or the capillary saturation. So why only the arterial saturation is being seen?
Because hemoglobin content, oxygen, hemoglobin is affinity of to oxygen is, it will detect.
Okay, so go and read a little bit about it. Okay, and what is the this thing relation between? So what you are measuring in pulse oximeter is SpO2, that is your saturation.
Yes,
Okay.
saturation.
And what is the best marker of the oxygenation? I mean, so ideally, what should we be monitoring, but we are not able to do because it is invasive?
Sorry, sir.
I mean, we are concerned with the oxygenation of the baby, right? I mean, we are
Yes.
monitoring SpO2 for any sick baby. Forget this baby, for any baby who's on ventilator, CPAP, you are always targeting oxygen saturation. So we are always worried about the oxygenation status. Okay.
Yes.
And to monitor the oxygenation status, we are measuring the SpO2, but that is an indirect marker. Okay.
Yes, sir.
So what is the best marker, or what is the most reliable marker of the this thing oxygen content of the blood?
ABGA, saturation of oxygen in blood. ABGA.
Yeah, so
Arterial.
that is PO2 levels in your
CO2.
blood. Okay, but that is invasive, so we are using SpO2,
Yes.
right? So what is the difference, or what is the this thing difference between the use of PO2 and SpO2? I mean, like there is a fallacy of using SpO2. Okay, so what is that? I mean, what is the difference between the two?
If there is slight if the saturation is around 84%, then the PO2 will be around 50 to 60. And at 94% SpO2, the PO2 is more than 90.
Okay. No, so then how does it affect your clinical management? What is the problem of using this?
Sir, I didn't get the question.
Okay, so see, the problem is that, I mean, your pulse oximeter saturation, even if it is 97 or 98, okay, PO2, I mean, with a pulse oximeter saturation of 97, PO2 can be anything above 80, right? It can be 90, 100, 110, 150, 210, 250, whatever be it. Okay? So, I mean, it correlates the linear relationship between SpO2 and PO2 has got a very thin margin. So that is why you always say that you want to maintain the babies between 90 to 95%, because you never know beyond 95 what level of hyperoxia the child has. Okay, I mean, the more severe the hyperoxia that baby on respiratory support has, more bad it is in terms of ROP and other diseases of the prematurity. Okay, so ROP, BPD, and other free radical injuries. So that is why, I mean, there is a very thin line on which we have to maintain a balance. The SpO2 is actually a surrogate of oxygenation, which we are using in our NICU because it is non-invasive and easily done at the bedside. But still, the best marker would be the arterial oxygen content. Okay.
Yes.
Okay. Then last question. Last question. How do you plan to manage this case now? I mean, what is the next plan of action in this case? Now, since you're telling that the child is on ventilator and stabilizing as of now, what is the long-term management?
Sir, long-term management is we are planning for the surgical management for this patient.
Okay.
So we are planning to refer this patient to higher center.
Okay. Okay. I mean, how have the parents been concerned about the this thing prognosis even after the surgery? I don't think the prognosis, I mean, would be very good, and maybe it is something which would need a not a single operation but a multi-stage operation, because as per your echo findings, the RV is a little bit hypoplastic, right? So, uh, okay. Okay, so I mean, because the RV is hypoplastic and there is pulmonary stenosis, I mean, the prognosis may be guarded even after the surgery, and that too, the parents have to be counseled that it is not something very simple. Just after the operation, the child is going to be fine or this thing.
Yes. The
Okay.
parents were counseled about that.
Okay, and how are the other two babies? They are doing fine.
Yes, sir. Screening echo was done for both of the baby, which was normal. Only small PFOs there on T2. T3, there is no abnormality seen on 2D echo. And
Okay,
both
so
babies are on room air.
okay, so for this baby, I mean, can you just show me the echo slide which you had shown?
Yes, sir.
Okay, next, before this one.
Yes.
So this one, what you have shown is the TR jet, which is around 46 or 48.
Yes, sir.
Yeah,
46.
so 46. So how do you interpret it? What should be the normal value, and when do you call it?
Sir, normal value is less than 30 millimeter of mercury. It is suggesting that some blood is going during right ventricular systole. Some blood is going from right ventricle to right atrium. So the flow is going back in right atrium. Normally it is 30 millimeter of mercury pressure, but in this case there is 46.
Okay, so what do you label it? I mean, it is moderate, severe, anything about that grading? Do you know?
No, sir, I don't know about the grading. But,
Okay. Okay. Okay, then about the pulmonary hypertension. So, I mean, this child had tricuspid regurgitation. So, what
yes.
else do you want to see in the echo for, I mean, if you're suspecting pulmonary hypertension or this thing, what are the other markers to look for in the echo?
For the pulmonary hypertension? For the pulmonary hypertension, we will see the dilatation of the right atrium. If there is no abnormality in tricuspid valve, then there also will dilatation of the right ventricle. And there will be reversal of the PDA blood from right to left if there is pulmonary hypertension.
So either there is reversal or there is a bidirectional flow in the PDA.
Yes, bidirectional.
Okay, other than that?
There is also TR jet is there in pulmonary hypertension.
Okay.
And IVC is dilated.
It may not be always, but
yes.
Okay. Okay. I think this is it from my side. Ma'am, we can wind up now.
Yes. Kunal, are you there? So, any feedback for the student, Dr.
Yes, ma'am.
Sandhya?
No, ma'am. I think it was quite good a presentation, as I told in the beginning, because they have managed the case quite well. I mean, I do understand that managing sick case with CHD, stabilizing is a very difficult task, and many times, even with the best of resources available, it is not possible to stabilize such cases. So, if they have been able to tide over the acute phase, that means that the team effort has been good. And I think a little bit more reading about this thing. When you are appearing for your exams, most of the times what the examiners prefer, see this case, you knew that the diagnosis, when you are presenting this case, you know that the diagnosis was pulmonary stenosis and this thing. So but for an examiner who is coming to take your exam, he will not know what the question is. So their questions will revolve around the basics of pulse oximetry screening and whatever you highlight in your history, like IUGR, feeding protocol for IUGR, and pulse oximetry screening. So all those are basic things which we expect you to know. because those are this thing. Because I mean, see, I'm not an expert to guide you about the management of pulmonary stenosis and all those things. But our job is like how to screen for that CHD. What are the criterias? RBSK. That is something which we as pediatricians and neonatologists have to know. So all those things are ones which you should focus on.
Yes. Thank you so much. And one more thing I just wanted to convey to the students with the Bollywood effect, if you say it is a, first you should think of a common thing in the triplets and the twins. When there is a weight difference or when there is a gestational age difference, it is a growth lag. Superfecundation and all that are very rare conditions. So common answers has to come first. And then if you want to really go into the detail, you can also answer rare. But rare things we have to, first we need to think of the common conditions. So in our country, there is more of a fetal growth retardation is more common, especially with the triplets, and even we with a maternal malnutrition, we are looking at the single also. So, but twins and triplets, fetal growth retardation is more common for the when there is an the there is a weight gap is there or the gestational age gap is there. So, Kunal, over to you. Dr. Kunal?
Sir, thank you so much. So it was a wonderful presentation. Thank you, Dr. Mansi, for an excellent presentation. Thank you, Dr. Sandeep, for asking such nice questions and informative questions. Thank you so much. Thank you, Maulik sir, for excellently guiding Dr. Mansi. Thank you, Dr. Krunal Shah, for excellent moderation. Thank you, Shwetal ma'am, for being there, as well as our EB members, Dr. Vijay, Dr. Vishal are also there, as well as Sheila ma'am has been there throughout. Thank you, ma'am, for being there with us. You are she is our advisor and has been guiding us for the Gujarat NNF. Thank you so much, ma'am. With this, if there are no questions are there, then we can end this session. Yes.
Yes, yes. Thank you.
Thank you all. Rupsa, we can conclude this session now. Rupsa. Yeah, I think everyone can leave. Yeah, thank you so much, everyone.
Thank you.
So thank you so much everyone for extending us the opportunity to host this session. So with this, we would like to conclude the session over here and looking forward to what you